Appendicitis.
Appendicitis is the most common abdominal emergency in children and adolescents. This video introduces the pathophysiology, classic history, and physical findings of appendicitis, as well as the required investigations and management.
The appendix is a blind diverticulum of the intestine located posteromedially to the cecum. It is a vestigial organ measuring between 8 and 10 centimeters in an adult. Here are the anatomically important structures of the appendix. The appendix can have different positions in the abdomen. Here are a few from most to least common: retrocecal, pre- or post-ileal, and pelvic. The proposed etiology of appendicitis is obstruction of the appendicular orifice. Some examples of things that can obstruct the appendicular orifice include fecaliths, lymphoid hyperplasia, or infections.
This obstruction causes an increase in intraluminal and intramucosal pressure, which leads to inflammation and eventually localized ischemia. Untreated appendicitis can become complicated by gangrene, abscess formation, or perforation. Perforation will lead to generalized peritonitis.
The natural history of appendicitis can explain the pattern of pain that typically accompanies the disease.
With the onset of localized ischemia, the parasympathetic nerves that lie near the orifice of the appendix and that correspond to the ganglionic roots from T8 to T10 are stimulated, creating a vague periumbilical or epigastric pain.
When the parietal peritoneum adjacent to the appendix becomes irritated and inflamed, the pain migrates from the midline to the right lower quadrant.
If the appendix perforates, the entire peritoneum will become inflamed and the patient may have generalized peritonitis.
Patients with appendicitis will initially present with vague periumbilical pain that intensifies over 24 hours and becomes more sharp and constant over time. The pain will then migrate to the right lower quadrant. Patients will often experience anorexia and nausea. Although this is the classically described presentation of appendicitis, only 50% of patients may present this way.
Many patients present atypically or at later stages of the disease. It's important to figure out when the onset of pain was and its evolution, with special attention given to the duration of symptoms. Knowing this information will help in establishing the diagnosis and deciding on management. Perforated appendices will cause sudden, severe pain and subsequent generalized peritonitis. Furthermore, it's important to establish if there's a history of inflammatory bowel disease, because Crohn's disease of the terminal ileum can present similarly to appendicitis. You must also ask about previous colonoscopies, especially in the older adult population. Occasionally, appendicitis can be the first presentation of an appendiceal or cecal cancer. In female patients, it is important to acquire a gynecological history, as different tubo-ovarian pathologies may also present as right lower quadrant pain.
Ask a resident. Should all patients with appendicitis experience loss of appetite, also known as anorexia?
If the patient isn't experiencing loss of appetite, you must seriously reconsider the diagnosis of appendicitis.
Start your physical exam with an evaluation of the patient's general appearance and vitals. Patients often present with low-grade fevers and tachycardia. On abdominal exam, there may be tenderness on percussion and palpation. Tenderness is most intense at McBurney's point, which is located approximately 2/3 of the way from the umbilicus to the anterior superior iliac spine. Rebound tenderness, localized muscular rigidity, involuntary guarding, pain with coughing, and pain that is worse with movement may also be observed.
Special tests can be performed to elicit pain from appendicitis. A positive Rossving sign is pain felt in the right iliac fossa when the left iliac fossa is palpated. This is due to peritoneal irritation at the right iliac fossa. A positive psoas sign is when the pain is reproduced when the right hip is passively extended or actively flexed. This is indicative of a retrocecal appendix, which typically lies over the psoas muscle, a hip flexor. A positive obturator sign is when the pain is felt in the right iliac fossa when the flexed right leg is internally rotated. This is indicative of a pelvic appendix. Unfortunately, the psoas sign and obturator sign have very low sensitivity.
Rectal and pelvic examinations are usually normal. The use of rectal exams is not supported by the literature. However, it could be important to perform a pelvic exam in order to rule out gynecologic problems.
Some laboratory tests that can be ordered include a complete blood count with differential white cell count. In most cases of appendicitis, you'll see an increase in leukocytes with a left shift. You should also order a urinalysis to look for pyelonephritis, renal calculi, and urinary tract infections. Check for dehydration and electrolyte imbalance, as well as kidney function. Order liver enzymes and bilirubin to check for possible hepatic or biliary causes, and lipase or amylase for pancreatic causes.
An INR is extremely important for older patients, patients with comorbidities, and those on warfarin. If this is appendicitis, then management will most likely require surgery. Therefore, we must assess the patient's clotting ability preoperatively. A beta-HCG is necessary for every woman of childbearing age in order to rule out pregnancy. Initial imaging modalities include chest X-ray when respiratory symptoms are present, abdominal X-rays in 3 views, and an ultrasound, which is especially useful in children. Although abdominal and pelvic CT scans are useful imaging tools, ultrasound remains the preferred method because it avoids unnecessary radiation and allows for adequate visualization of the appendix. CT is most often used if the diagnosis remains unclear after history, physical, and ultrasound.
Ask a resident. What are some urologic signs and symptoms in patients with appendicitis?
Patients with appendicitis can have mild hematuria and pyuria. This is due to ureteral inflammation.
Ask a resident. What is the name of the clinical prediction tool for appendicitis?
The Alvarado score. Its components can be remembered with the mnemonic MANTRALS: migration of pain, anorexia, nausea and vomiting, tenderness in the right lower quadrant, rebound pain, elevated temperature or fever, leukocytosis, and left shift.
Appendectomy is the main treatment for appendicitis. It can either be laparoscopic or open. Both methods have advantages and obstacles, but a laparoscopic approach has become the preferred method at most centers. If a normal appendix is found, the diagnosis must be reevaluated. Patients with atypical presentations or late presentations will have an increased risk of complicated appendicitis. Gangrene, abscesses, and perforation are common with delayed presentations, which occur approximately 4 to 5 days after the onset of symptoms. A non-operative approach is preferred for such cases. IV antibiotic treatment, fluid administration, and bowel rest is typically the treatment for late perforated appendicitis. Patients must also be closely monitored for worsening symptoms due to uncontained sepsis and generalized peritonitis. Those patients may require surgery to obtain source control.
In patients with abscess formation, the appendix may become walled off, which means that the abscess has perforated but is contained. This type of walled off appendix is usually treated non-operatively before appendectomy is considered. In the case of a walled off abscess, a percutaneous drain can be placed in addition to the other management strategies. Other cases when you can use a non-operative approach are for patients who have a perforation, a strong preference for a non-operative approach, or those who are high-risk surgical candidates. Preoperative preparation includes administration of analgesics and antibiotics, fluid resuscitation, and correction of electrolytes. Many different analgesics can be used to control pain. Non-perforated cases should receive antibiotics to cover gram-negative bacteria and anaerobes. Antibiotics are given to all patients before surgery, and if the appendix isn't perforated, the antibiotic regimen is usually discontinued. If the appendix is perforated, the antibiotics are usually continued to reduce the risk of developing an abscess post-operatively.
A recent randomized controlled trial published in JAMA has found that the use of broad-spectrum antibiotics such as ertapenem alone in uncomplicated acute appendicitis confirmed by CT scan can be safe, and that up to 72% of patients treated with antibiotics alone did not require an appendectomy after 1 year follow-up. While the antibiotic group did not meet the predefined non-inferiority criteria, it suggests that a non-operative approach could be a reasonable option for comorbid patients with high surgical risk or strong preference to avoid surgery.
However, the trial also found that the use of antibiotics alone increased hospital stay, and that 27% of patients went on to have surgery within a year of antibiotic treatment, which means that there is still a significant risk of future attacks. The risk of developing antibiotic resistance is also a potential concern. Remember that when deciding on your treatment plan, the patient's point of view must always be taken into consideration, with good understanding of the risks and benefits.
An interval appendectomy is a management strategy that may be used in more complicated cases of acute appendicitis. This includes appendiceal abscesses and perforated appendices. At the time of initial presentation, management begins with analgesia, antibiotics, and fluid resuscitation until the acute disease resolves.
Several weeks after the acute process resolves, a discussion with the patient can be had about scheduling the elective interval appendectomy. Certainly, if they have ongoing chronic symptoms, this should be advised. If they are asymptomatic, there is an unclear benefit, but it often comes down to patient preference. This management strategy may reduce the chances of recurrence, but its use is debated due to conflicting evidence. As usual, the patient should be informed of the benefits and potential risks of this procedure.
Since appendicitis is so common, you should pay special attention to the atypical or late presentations in order to prevent complications.
The creation of this video was supported by the UGME Innovation in Undergraduate Medical Education Summer Studentship and the University of Ottawa.